mga kadok. Welcome back to another episode of Immunology. So today we're going to be talking about type 1 diabetes, its characteristics, risk factors, signs and symptoms, and how it is treated. So without any further ado, let's jump straight into the topic. Okay. So for the first slide for type 1 diabetes, there's an illustration comparing a healthy pancreas and a diabetic pancreas. So for the diabetic pancreas, it says immune cells destroy beta cells in the pancreas. So these beta cells are cells found in the pancreas which produce insulin in the presence of glucose. So if these cells are destroyed, no insulin would be produced, and then the glucose in the blood will not be lowered, and then will eventually accumulate in the blood and rise in the blood. So for the introduction, diabetes mellitus is a group of metabolic disorders characterized by hyperglycemia. So it's associated with abnormalities in carbohydrates, fats, and protein metabolism. So this results in chronic complications including microvascular, which is a disease of the small blood vessels, macrovascular, which is a disease of the large blood vessels, and then neuropathic disorders, including the nerves. So diabetes is the leading cause of blindness in adults aged 20 to 74 years old, and it is also the leading contributor to development of end-stage renal disease. So ESRD. It also accounts for approximately 82,000 lower extremity amputations annually. So type 1 diabetes is also known as your insulin-dependent diabetes mellitus or juvenile onset diabetes mellitus. So this type of diabetes is diagnosed usually in children or adults younger than 30 years of age, although this disease can be present in any age actually. This form is characterized by an absolute deficiency in insulin resulting from pancreatic beta cell destruction. So like I said earlier in the first slide, if the beta cells are destroyed, no insulin will be produced, and then the blood glucose cannot be lowered. The body does not produce insulin, thereby causing increase in blood sugar. So this is a comparison of type 1 and type 2 diabetes. So for type 1, the onset is usually sudden, while in type 2 it is gradual. The age of onset for type 1 is any age, but more commonly in the young children or young adults. And then type 2 diabetes usually mostly occur in adults, so later in life. So the body habitus, or the body shape for the type 1 diabetes is usually thin or normal, while for type 2 they are often obese. So ketoacidosis is usually common in type 1 diabetes, while for type 2 it is rare. And then autoantibodies, since type 1 diabetes is a autoimmune disease, because the body produces antibodies that will cause beta cell destruction, autoantibodies are usually present, while type 2 diabetes it is absent. For type 1 diabetes, endogenous insulin is usually low or absent, while your type 2 diabetes is normal, decreased, or increased. So in coordinates of identical twins, it's more commonly 50%, and then for type 2 is 90%, and then for type 1, it's less prevalent, while type 2 is more prevalent. So 90 to 95% of US diabetics. So this is probably caused by lifestyle, unhealthy diet, not having enough exercise, and so on and so on. So typically, type 1 diabetes is an autoimmune disorder developing in childhood or early adulthood, although some latent forms do occur. Type 1 diabetes accounts for 5% to 10% of all cases of diabetes and is likely initiated by the exposure of genetically susceptible individuals to an environmental agent. So there is a trigger factor. Candidate genes and environmental factors are reportedly prevalent in the general population, but development of beta cell autoimmunity occurs in less than 10% of the genetically susceptible population. So this progresses to type 1 diabetes in less than 1% of the population. So for classification, in general, diabetes is a metabolic disorder characterized by resistance to the action of insulin. So since, like I said earlier, the action of insulin is to lower blood glucose. It does this by allowing glucose to enter the cell and then used for energy. And then, the clinical manifestation of these disorders is hyperglycemia. So this is the key term for diabetes, hyperglycemia. The majority of diabetic patients are classified in one or two broad classifications, which are your type 1 diabetes and then your type 2 diabetes. Type 2. So your type 1 are caused by an absolute deficiency of insulin. So there is little or absence of insulin produced by the pancreas. Excuse me. While your type 2 diabetes, it is defined by the presence of insulin resistance with an adequate compensatory increase in insulin secretion. So basically the difference between type 1 and type 2 is that your type 1, there is low or no insulin, while your type 2 can produce insulin, but it becomes resistant to the insulin, so there's no effect. There's no effect. So women who develop diabetes because of the stress of pregnancy are classified to be having gestational diabetes. But since our subject for today is immunology, we'll be only talking about type 1 diabetes, which is an autoimmune disease. So this results from an autoimmune destruction of beta cells of the pancreas. Markers of immune destruction of the beta cell are present at the time of diagnosis in 90% of individuals, including islet cell antibodies, antibodies to glutamic acid decarboxylase, and antibodies to insulin. Although this form of diabetes usually occurs in children and adolescents, it can occur at any age, like I said earlier. But however, it's more common in the younger individuals. So these typically have a rapid rate of beta cell destruction and present with ketoacidosis. So like I said earlier, type 2 diabetes is rare to have ketoacidosis. For the pathophysiology, type 1 diabetes is the accumulation of lymphocytic infiltration and destruction of insulin-secreting beta cells of the islet of Langerhans in the pancreas. So after 80 to 90% of the beta cells are destroyed, hyperglycemia develops. So since the beta cells are destroyed, there's no insulin production or insulin secretion, which allows the entrance of glucose into the cells, and they stay in the blood, causing hyperglycemia. And then diabetes may be diagnosed. The most found islet cell antibodies are those directed against the GAD, or their glutamic acid decarboxylase. So this is an enzyme found within the pancreatic beta cells. So this is a diagram of how the pathophysiology of diabetes occur. So it can either be a genetic predisposition or an environmental factor that triggers the autoimmune destruction of your beta cells. So autoantigens form on insulin-producing beta cells and circulate in the bloodstream and lymphatics. So this process and presentation of autoantigens by antigen-presenting cells, or APCs, so they can either cause activation of T helper 1 lymphocytes or activation of T helper 2 lymphocytes. So your T helper 1 lymphocytes produce interferon gamma or interleukin 2. So these usually just produce macrophages or autoantigen specific T cytotoxic cells, or CD8 cells, and then lead to the destruction of your beta cells and decrease insulin destruction. While your activation of T helper 2 lymphocytes produce interleukin 4 which activates your B lymphocytes to produce islet cell autoantibodies and anti-GADs, or your anti-glutamic acid decarboxylase antibodies, which also lead to the destruction of beta cells and decrease insulin secretion. So next is screening. So there is still a low prevalence of type 1 diabetes in the general population, and because of the acuteness of symptoms, screening for type 1 diabetes is not recommended. However, the easiest way to differentiate between type 1 and type 2 DM is by measuring the C-peptide levels. So usually for type 1 diabetics, C-peptide levels below 1 ng per ml, whereas your type 2 diabetes will have a value greater than your 1 ng per ml. Next is your diagnosis. So the diagnosis of diabetes requires the identification of a glycemic cut point. So this discriminates the normal persons from diabetic patients. So the ADA recommends using the fasting glucose test, or FGT, as the principal tool for the diagnosis of DM in non-pregnant patients. In addition, they defined a new category of glycemia, which is known as your impaired fasting glucose, or your IFG. So your IFG is a plasma glucose of at least 100 milligrams per deciliter, but less than 126 milligrams per deciliter. Impaired glucose tolerance, or IGT, it is defined as a 2-hour glucose value of greater than 140 milligrams per deciliter, but less than 200 milligrams per deciliter during an OGTT, or a oral glucose tolerance test. So patients with either IFG or IGT are commonly referred to as having pre-diabetes. So diagnostic tests including your hemoglobin A1C, fasting plasma glucose, or FPG, or your OGTT, or your oral glucose tolerance test. So for your hemoglobin A1C, so this test measures your average blood glucose for the past 2 to 3 months. So this test is considered to be the gold standard. So glucose interacts spontaneously with hemoglobin in the red blood cells to form glycosylated derivatives, or the HbA1c. So this test shows the amount of glucose that sticks to the red blood cells, which is proportionally to the amount of glucose in the blood. So the lifespan of your red blood cells is around 120 days, or around 3 months. So this glucose binds to the hemoglobin, and this test can measure the amount of glucose that was present for the past 2 to 3 months. So diabetes is diagnosed at an A1C of greater than or equal to 6.5%. So this illustration will depict the A1C test results. So diabetes is diagnosed with an A1C test 6.5% or higher, and the normal would be below 5.7%. So any value between those two would be considered pre-diabetes. Next is the fasting plasma glucose. So when we say fasting, it means to not have anything to eat or drink except for water. So this lasts for at least 8 hours before the test. This test is usually done first thing in the morning before breakfast. So diabetes is diagnosed using this test, fasting plasma glucose, greater than or equal to 126 milligrams per deciliter. So in the illustration to the right, no food or drink for 8 to 12 hours prior to the test, or before the test. So blood is drawn and tested for the level of glucose in the blood. So high glucose levels equals potentially diabetes. Next is the oral glucose tolerance test. So this test is a 2-hour test that checks your blood glucose levels before and 2 hours after you drink a special sweet drink. So it's 2 hours before and 2 hours after. So the results of this test will provide information to the physician on how your body processes glucose. Diabetes is diagnosed with this test with a value of greater than or equal to 200 milligrams per deciliter. So to the picture to the right, It's the same thing as fasting. So you have no food or drink 8 to 12 hours prior to the test, and then you drink this special sweet drink. You drink the glucose drink, and then blood is tested 2 hours later after. So high glucose levels are potentially diabetes. This graph, this graph or this table shows a summary of the 3 tests and their abnormal results for diabetes, pre-diabetes, and normal results. Next is the clinical presentation. So in this table to the left, the clinical presentation of diabetes mellitus. So I'm going to be running down for type 1 diabetes only. So for the age, occurs less than 30 years. Onset is abrupt, like we said earlier. This is just another comparison picture. We don't need that. So for clinical manifestation, the most common symptoms of type 1 diabetes mellitus are polyuria, polydipsia, and polyphagia. So these are the triad symptoms of type 1 diabetes. So along with the lassitude, nausea, and blurred vision, all which result from the hyperglycemia itself. So for the desired outcomes for type 1 diabetes, so the primary goals of DM management are to reduce the risk for microvascular and macrovascular disease complications, to ameliorate symptoms, reduce mortality, and improve quality of life. Hyperglycemia not only increases the risk for microvascular diseases, but also contributes to the poor wound healing and compromises white blood cell function and leads to classic symptoms of your diabetes mellitus. Diabetic ketoacidosis and your hyperosmolar hyperglycemia state are severe manifestations of poor diabetes control. So this is invariably requiring hospitalization. So it's better to stay at the hospital for better control of these states. And then reducing the potential for microvascular complications is targeted to adhere to therapeutic lifestyle interventions. So these lifestyle interventions include healthy diets, and then exercise programs. So it's better to be physically fit or increase physical activity. And then there's also drug therapy regimens, as well as maintaining blood pressure as near normal as possible. So what is the general approach to treatment? So appropriate care requires goal setting for glycemia. You have to treat the glycemia, blood pressure, lipid levels, regular monitoring of complications, dietary and exercise modifications, medication, appropriate self-monitoring blood glucose, and then laboratory assessment of the aforementioned parameters. So glucose control alone does not sufficiently reduce the risk of macrovascular complications in persons with DM. So for your non-pharmacologic therapy, this basically includes your diet, healthy diets, and then increased physical activity. So for diet, medical nutrition therapy is recommended for all persons with DM. So paramount for all medical nutrition therapy is the attainment of optimal metabolic outcomes and the prevention and treatment of complications. So we have to treat the complications that are associated with your diabetes type 1. For individuals with type 1 diabetes, the focus is on regulating insulin administration with a balanced diet to achieve and maintain a healthy body weight. So a meal plan that is moderate in carbohydrates and low in saturated fats with a focused on balanced meal is recommended. The amount or grams of and type of carbohydrates, whether accounted for by exchange or carbohydrate counting, should also be considered. So these are a short list of foods or a short table of that are contained in a type 1 diabetic diet. So for bread, cereals, and other grains, we have breakfast cereals, rice, pasta, noodles, flour, biscuits. For starchy vegetables and legumes, we have potatoes, sweet potato, corn. For fruits, fresh fruit, so on and so on. Dairy products, milk, yogurt, custard, and ice cream. And then sugary foods and drinks, lollipops, honey, jam, cakes, and regular soft drinks, and cordial. Next is your physical activity. So in general, most patients with DM can benefit from increased activity. So such as aerobic exercise improves insulin resistance and glycemic control in the majority of individuals and reduces cardiovascular risk factors, contributes to weight loss and maintenance, and improves well-being. The patient should choose an activity that she or he is likely to continue. So it has to be an activity that they enjoy, that they like, so that it is consistent. So physical activity goals include at least 150 minutes per week of moderate, which is considered to be 50 to 70% maximal heart rate of intensity exercise. So that's skateboarding. Next is pharmacologic therapy. So patients with type 1 diabetes mellitus, they require lifelong insulin therapy. So I'll just cut that. COVID. Just kidding. So for pharmacologic therapy, patients that have or are diagnosed with type 1 DM, they require a lifelong insulin therapy. So most they need lifelong insulin therapy because, like I said earlier, they have little or low or absence of insulin produced by their pancreas. So most require 2 or more injections of insulin daily, with doses adjusted on the basis of self-monitoring of glucose levels. So this glucose levels is to replace the endogenous loss of insulin from the non-functional pancreas. Usually patients who have type 1 diabetes take a combination of types of insulin, such as a long-acting insulin once or twice a day and a rapid-acting insulin before each meal. So these type 1 DM patients, they are frequently started on about 0.6 units per kilogram per day, and these doses are titrated until glycemic goals are reached. So currently, the most advanced form of insulin therapy up to date is the insulin pump. So this is also referred as the continuous subcutaneous insulin infusion. So this is a pump, uses short or rapid insulins only. So this is the pump. And then it is programmed to provide a slow release of small amounts of insulin as the basal portion of therapy, and then larger bolus doses are injected by the patient to account for the consumption of food. So for insulin, so this is basically what type 1 diabetics will be using throughout their life. So insulin can be divided into 4 separate classes based on their length of action. So it can either be rapid, short, intermediate, or long-acting. So most formulations are available as 100 units, indicating U100 or indicating a concentration of 100 units per ml. These insulins are typically refrigerated. However, most vials are good for 28 days at room temperature. So this is just a general list of the types of insulin. So we have here. There's your rapid acting insulins, which we'll discuss these 4 later on. So your rapid acting insulins, these include your Lispro, glulicine, and aspart insulin. Your Lispro insulin is a form of regular insulin that is genetically engineered with the reversal of amino acids, lysine and proline, at the B28 and 29 in the beta chain. So glulisine insulin substitutes glutamic acid for lysine in the position of B29, while your aspart insulin substitutes aspartic acid for proline in position of 28 of the beta chain. So this is just a illustration. Like we said for insulin glulisine, ayan, glulisine replaces lysine at beta 29, while your insulin aspart replaces proline with aspart, your ASP at B28, and so on and so on. So these rapid-acting insulins, these are absorbed more quickly and have a rapid onset of action. So these rapid-acting insulin, they act in 5 to 10 minutes. So a short interval to peak action is about 45 to 75 minutes, and then a short duration of action, which is they act for 2 to 4 hours. So therefore, they can be administered shortly before eating. In addition, your NPH insulin will not inhibit the action of insulin lispro when the two agents are mixed together right before injection. So this is not a true regular insulin. Next, we have your short-acting insulin. So this includes only your regular insulin. So this insulin preparation contains zinc insulin crystals in solution. When it is administered subcutaneously, the onset of action occurs in half an hour. Its peak activity comes at 2.5 to 5 hours, and its duration of action is 4 to 12 hours. So both regular human insulin and rapid-acting insulin analogs are effective at lowering postprandial hyperglycemia, and various basal-boluses regimens include used in type 1 diabetes. So your intermediate-acting insulin. So this type of insulin includes your NPH, or your neutral protamine Hagedorn insulin. So it is a crystalline suspension of human insulin with protamine and zinc. So it provides a slower onset of action, but a longer duration of action than regular insulin does. So its onset of action is 1 to 2 hours, peak effect is noted at 4 to 12 hours, and duration of action is 14 to 24 hours. So this type of insulin can be mixed with either aspart or lispro, which are rapid-acting insulins, but it must be injected immediately after mixing. Whenever mixing insulin products with NPH, the shorter-acting insulin should be drawn into the syringe first. Next is long-acting insulins. So this includes your insulin glargine and your insulin detemir. So glargine and detemir are designed as once-daily dosing basal insulins. Your glargine has no peak and produces a relatively stable level lasting more than 24 hours, while your detemir has a duration of action that may be substantially shorter than that of glargine, but longer than those of intermediate-acting insulins. So glargine cannot be administered intravenously or mixed with other insulin products, but both glargine and detemir can be administered irrespective of meals or time of day. So next is your mixed preparations. So mixtures of insulin preparations with different onsets and duration of actions frequently are administered in a single injection by drawing measured doses of the two preparations into the same syringe immediately before use. So take note, immediately. The exceptions are insulin glargine and insulin detemir, which these are your long-acting insulins that they cannot or should not be mixed with any other form of insulin. Preparations containing mixtures of 70% NPH and 30% regular human insulin, example would be the brand of Novolin 7030, Humulin 7030, and so on, are available by the fixed ratios of intermediate-acting or long-acting to rapid-acting insulin that may restrict their use. So that is the end of the PowerPoint. Thank you for listening, and I'll see you guys next month. Stay tuned for another episode by the next reporter, and have a good day. Straw heart. Straw signature.
Like a Hellcat.